Hello, Reward clinicians, and welcome to another case review. I have the pleasure of being with Dr. Michael Lewis. Dr. Michael Lewis, thank you for joining me.
My pleasure, my pleasure.
Dr. Lewis is the director of the Foundation Endodontics in Teaneck, New Jersey, as well as on the faculty at the Hackensack University Medical Center. Michael, you have a few cases here for us today. We're going to go through the first one, and then we'll do the other two in separate videos. So why don't we get started right away and get to the case. I saw this case on Endolit, and I really enjoyed it, and I wanted to share it with our viewers as well. So this is the case of a mandibular first molar that saw you with a previous endo and a large lesion. Obviously, it's failing. So why don't you please go ahead and describe your treatment and what you did for our viewers.
Okay, so patient was a 19-year-old male. He presented with swelling adjacent to number 31, and took a radiograph, and we see this large periapical lesion, and he actually had a large buccal swelling associated with this tooth, with probing down to the apex. You know, whenever you're confronted with probing to the apex, the first thing you got to think of is, what's the etiology? Is this probing due to a fracture? Is this probing due to a perforation? Is this probing due to an endoperioral lesion, with different associated prognoses associated with each case? Unfortunately, there's a tendency out there for people to kind of say, oh, probing to the apex, poor prognosis, let's get rid of it and take the tooth out and place an implant. And you know, I think all the people who are viewing this video probably can appreciate just how unfair that might be to the patient, because oftentimes if it is an endoperioral lesion, the prognosis can actually be quite good if you can deal with the endodontic infection. You know, patients, particularly as young as this, have tremendous capacity to regenerate the bone tissue around this tooth. So because we took a look and we saw that probing was really associated with the buccal aspect, it had nothing to do with the medial or distal, you know, my index of suspicion for fracture was quite a bit lower. And we said, let's open up the tooth, let's take a look inside and see if there is a fracture. We took a look at the tooth, we opened it up, and we look at the walls. You know, there's no fracture, certainly nothing mesially, nothing distally. Took a look at no evidence of any post-perforation or anything like that. So we went ahead with retreatment, as you'll see it as in future slides, was probably a pretty good call here. So we went ahead and retreated this tooth, and I'm sure some of your viewers might disagree with this, but I opted to do it in a single visit. The patient was young, and I had concerns whether he would come back or not. And in general, I really don't have much of an issue doing these cases in one visit. The patient actually ended up being quite responsive and was able to return 1 year for a follow-up. Here you can see the post-op images, and here you can see the final, the post-op image 1 year later. Showed excellent healing. Probing was circumferentially less than 3 millimeters. Really, I was very pleased with this result. I'm sure that lesion will continue to fill in with denser bone as time goes on, but at this point, I would say this tooth is well on its way to having excellent and full and complete healing. Feel free to probe with any questions you might have, Alan.
Yeah, I mean, Michael, I think you did a wonderful job handling the case in terms of the treatment planning, the decision to extract or go with a retreatment. I think you did the right thing. Without any direct evidence of a fracture, it's very difficult to tell someone to extract their tooth, because at the same time, you're gambling with that potential for a fracture as well. There's no way you can tell without any direct observation that the tooth is fractured. So it might be a guesstimate. So I think in a sense, you kind of have to make a judgment call based on the patient's motivation for keeping the tooth versus their risk averseness for taking a chance and finding out that the tooth is fractured. I think at the very least what you did was best is to at least go inside the tooth and confirm whether you can see a crack or not, because if you don't, then the odds may change significantly. Michael, what has been your experience in the past with mandibular second molars, where the roots have fairly good proximity in a form of a fused root, and that oftentimes leads apical failure, results into a sulcular type of a sinus tract that mimics that kind of a deep fracture? Do you see that often, specifically in these types of cases?
Until you brought my attention to it, that was not something I ever really appreciated. So I actually learned quite a bit from one of your comments before on the forum that we had actually met. That is not something that I was cognizant of before. And when I think back upon my clinical experience, that does seem to ring true. I'll have to look at it more closely, but it does jive with my clinical experience. I can't tell you that I have direct experience in terms of, but I will be on the lookout for it.
Yeah, I mean, we all know, we learn in dental school that infection follows the path of least resistance. So certain geometrical situations in which the bone and the roots have fairly favorable types of anatomical morphology that allows for drainage to follow that path tend to be more common. And I have seen that quite a bit happen clinically as well. Some of the other questions about removal of the post in this case, you did that through the crown. What were some of the strategies that you would recommend for viewers to see in terms of post removal in these kind of cases? And this seems like, the same type of a post was reapplied, hopefully not the same post, but how did you remove these types of posts? Are fairly active. So what was your strategy there?
Post removal, I think at this point in my career, it doesn't really take me that much time. Just going through the steps. I remember when I first started dealing with post removals, it was always a challenge. As time goes on, I think I've gotten a little bit more aggressive in terms of removing these posts, and that's allowed it to be expedited quite a bit. In terms of learning curve, it's a little steep at first, but at this point, in terms of my approach to these cases, is I'll really go in with ultrasonics, and if I have to remove a little bit more tooth structure with a fine diamond burr, or particularly around the outer curvature where the post is binding, that seems to really free up the post quite easily. And in this case, it certainly looks like the same post, so I understand where you're coming from, but no, it was not the same post. That post was removed and thrown out.
I know, you kept it to make sure that they don't replace the same one, I'm sure. But did you have to unscrew this one? Sometimes after vibration, when you have an active post like this, unscrewing would be the trick. Do you use any chemicals as well? Any chloroform do you find to be helpful, or just purely vibration forces?
I typically go around it. I will trace the perimeter of the post with a 556 burr initially, and then I'll go in with ultrasonics and just move in a counterclockwise direction, and the post just works its way out. Nothing more fancy or sophisticated than that.
Yeah, well, you did a great job removing it very conservatively without really removing excessive tooth structure. Michael, this case illustrates a very interesting concept that if you look at the pre-op radiograph, you would say that that endo looks fairly good, and that it goes to show that you can't just judge endodontic cleaning and shaping and disinfection from the radiographic look, because that is merely a radio density, which is a function of whatever material they use and how much zirconia or barium, barium or any kind of a radio pacifier agent is in the material. So what do you think, in terms of your experience having seen cases, is the impact of the look or radiography on the success rate of these cases? So when you see a case that's done seemingly well radiographically and it's failing, it does tend to, create a little bit of a problem for you as a clinician trying to make a decision as to whether this thing is a crack or it is a failing endo due to inadequate cleaning and shaping. Do you have any tips or tricks for that?
This is definitely a very important question in endo. I mean, we see thermosil cases all the time that look great, and then when we go in, we look and we see definitely signs of bacterial contamination inside the tooth, and it's really due to an inadequate debridement. In this particular case, when I went in and removed the canal, if we can just remove the post, if you look at the distal canal, you'll notice there's more of an ovoid shape. I don't know, Alan, can we move back a slide or two?
Yeah.
Look at the access. The etiology for failure here was, if you look at the distal root, it was, you could see now that it's broadened out in the buccolingual direction. There was actually a missed distal lingual canal, or at least the distal lingual portion of that distal canal was really under debrided pretty significantly. In addition, the mesial canals were really quite underdebrided. I think oftentimes what happens in these young patients, it's very easy to go in there and get patency and get down to the end of the canal, but I think people fail to appreciate just how wide these canals can be in a buccolingual dimension. And I see more failures on these younger patients, and I see more quote-unquote good-looking root canal in these younger patients. And what's happening is the clinicians that are attempting these root canals really are failing to respect just how wide these canals can be in a buccolingual direction. And that's what caused the failure in this case.
You're absolutely right. That's very common also, especially in the distal root, where people find one main canal, and oftentimes there is a lip of dentin or a shelf of dentin covering either the buccal or the lingual aspect of the root. Do you find Dr. Rankow's little article that was published where he has a symmetrical type of a thing? If you find a distal root, it has to be basically almost perpendicular to a line that crosses the two mesial roots in order to find out if that's the only distal root or there is a buccal or lingual one to that as well. You familiar with that?
Oh, I'm totally in agreement with that. When I was in school, we learned that as the law of centrality, that the canal really has to be in the center of the root, and it eccentrically placed. Guess what? There's another canal there, or there's no
look on the buccal or the lingual based on that. Yeah, you're absolutely right. The little lip or fissure canals that are keyhole looking, where there's a little bit of an extension buccolingually, as you mentioned. Those really are the challenge of cleaning and shaping, because our instruments are designed for round canals. However, all canals are more oval in one or the other direction, which emphasizes the importance of disinfection. I will ask you a question about your disinfection protocol in the next video. Well, thank you so much for joining me, Michael, and let's come back and do another case.